We want to invite Nick, who's kind of like the father of this endeavor of the HOT-HMV study, to tell us about, what's the learning of it? How did they achieve the results that they got? And how can we learn from that for our clinical care of these difficult patients?
Thank you to both ResMed and Philips for putting on this meeting tonight. And I really want us to dig down into this trial. It was a trial that, like many trials, took a long time to bring to fruition. And really, I just want to give you some background of where we are. I don't want to give you the background of the trials that failed, because we all know those trials. I want to give you the background of how we approached this to develop a trial team that managed to deliver a trial with virtually no dropouts. And I think that needs to be the credit of the HMV UK NIV network that we've set up over the last few years. And our own trials program, and I must highlight not only Patrick Murphy, who's really been instrumental in leading this trial, Jill Ibane, who's our clinical trials coordinator, John Moxham, who has driven many people and made them, better than they should be, I think is probably right, and Mike Polke. So this is how it all started. The then Prime Minister, Tony Blair, suggested that the UK should have a global medical excellence cluster and that respiratory medicine should be one of these clusters. This was a cluster to enable us to compete at the highest level internationally. It's nice to see Adrian's laughing because I know when it started. So, and this was driven by Tak Lee, Peter Barnes and Visha. And in fact, I remember the meeting we were at back in 2007. And there were some seriously talented people in the room. Now what it did, it drove us to come up with suggestions that we thought could be game changers in terms of respiratory medicine practice. And in fact, I discussed and I presented the whole idea of non-invasive ventilation in COPD. That led on to development of a grant application. That grant application went through Respironics, as it was then, rather than Philips Respironics, now Philips. ResMed, the ResMed Foundation, and also, importantly, Guy's and St Thomas's Charity, which is the charity that supports our institution. We had it funded in September 2009, and we recruited the first patient in February 2010. This was one of the first NIHR portfolio studies, and it was one of the first portfolio studies in respiratory medicine. In the UK, we have a research infrastructure which promotes clinical trials with good questions, and that actually gives a funding resource not only to your grant application but to underpin trials so you get to the point of not losing patients in clinical trials, that we see them all the way through and the dropout is low. The last patient was recruited in March 2015, and I'm very grateful to Holger because I think at that stage he sent us a bottle of champagne, which we didn't touch because there's no point touching something until you've got any data. So we waited, and we had to wait another 12 months as this was a 12-month follow-up, and we had no access to the data. The MRC Clinical Trials Unit in London held the data. So we had no idea. We knew the event rate was high. The Data Monitoring Committee, who had met every 6 months, hadn't shut us down. So we knew we weren't causing harm. And so this then led on to the actual data being released to us, which was in May. And I remember it was when I landed from the ATS, and I got an email from the MRC Clinical Trials Unit, and I'm the only person in the world, as has been pointed out at this meeting, to still have a BlackBerry. And I tried to open it, and all I could see was a Kaplan-Meier plot with a red line and a blue line, and they were hugely separated. And I didn't know which was the treatment arm and which was the control arm. So luckily enough, when I rang Paddy, he said, you can rest and sit down. It looks like it's going to be interesting to actually get to the bottom of his data. So we put the primary outcome in. I just want to highlight, this was the application. I've taken it out today and just cut and paste it in, but the huge amount of people that contributed at the beginning of this trial across the UK is incredibly impressive. People gave up their time for free. People were driving us to make sure that this worked. People were supporting this trial, and that was absolutely fantastic. I know at the beginning stage, having Mark Elliott, Peter Calverley, Visha, obviously with John Moxham and Mike Polkey helping us drive this along was absolutely incredible. And then John Gibson, who has given so much time to this trial as the Trial Steering Committee Chair. So you've heard from Paddy, and I just want to take out some messages which I think are really clinically important. These are sick COPD patients, but we don't have any treatment options outside of oxygen therapy for them. We have no other way to be able to treat them. They're all beyond nebulizers, all beta agonists, inhaled, anticholinergics, long-acting beta agonists, inhaled corticosteroids. We have very little for them. They are sick. So we took a very sick group. Now, our concern was, are they going to be too sick to respond to treatment? I spent part of my job in the ICU, and we've been absolutely nailed by trials which we've just taken too sick patients, so you can't see a difference. So this was a real major concern. It was been the concern until I actually saw the primary endpoint. So what was the intervention and control group? I know everybody's been discussing this, and we put it out, and it was HOT-HMV versus HOT. But how did we get to that? First of all, I'd just like to highlight, why did we call it HOT? Because it's home oxygen therapy. Why do we call it home oxygen therapy, not long-term oxygen therapy, or LTOT? Well, we had about a 2-day discussion around this because it's all to do with stability of calling it LTOT or not. So this was really important that people engaged enough and passionate enough that we were going to get the nomenclature right at an early stage. And so home oxygen therapy seems much more appropriate in a group of patients that lack clinical stability. You've heard that Wolfram and Michael and Jan were really driving through on the high intensity front, high backup rate, high pressure. What were we going to do? High pressure, high intensity? We had concerns. So in fact, this led us to do a randomized crossover trial, and we landed with the fact that high pressure was not worse or better than high intensity. Why is it important for us to know this? Well, if you have a ventilator with a high backup or a mandatory backup, what we might find is this technology, if it was positive, would be very expensive. And the more adaptations to a ventilator, the more expensive we can get. We're thinking this is going to be a relatively large population, and so we need to have, for healthcare funding, we need to have cheap ventilators. Hence why we chose high pressure. And also we were satisfied, and we are satisfied, obviously this data came out 2 years ago, by Thomas Kernline's study, because that used moderate pressure with a backup rate of 16, so somewhere in between the two. We also had a long discussion about a sham device, and obviously we had John Stradling, who has been excellently supportive of this trial, and he's done the sham trials with CPAP. We had a long discussion, but there was huge clinical concern. This increase in dead space with zero pressure support, we thought could be very detrimental to the patient. And so we decided that we would not use a sham device. Also, blinding, it doesn't become blinding. The patient knows they're not on ventilation. And so then it becomes irrelevant. And so when you're thinking of doing these trials, these technology trials, a clear thought process helps you to understand what the best approach is. And what about, Paddy says, 17 patients we had readmitted in the control arm, and we then put them onto treatment. And that was madness, because that dilutes out your treatment effect. And in fact, there was 1 or 2 in the room that were very passionate that this should not be done. However, after long discussions, it was agreed if the patient requested and the physician requested and agreed, together then patients could receive home mechanical ventilation, home oxygen therapy. But we knew this could actually dilute out our effect. So it was important for us to think through this carefully, and because this is intention to treat, if it did actually show a difference, then we've really shown a difference. This isn't just a small difference, it's a large difference which we've diluted down. So the primary outcome, admission-free survival, which we all agree is a very strong primary outcome. It's important to the patient. Important to the patient, obviously dying is important to the patient, but readmission to hospital is very important to the patient. The patient, when they're readmitted to hospital, gets a fall in their lung function. They get a reduction in their health-related quality of life. This is a bad event, and we need to try and have all ways to prevent it. What does the actual Kaplan-Meier tell us about this study? This is the important points that I've taken away, that the HOT-HMV treatment reduced the likelihood of readmission or death by almost 50%. HOT-HMV increased the time to readmission or death by over 90 days. The importance of thinking about this and never look at secondary analysis or post hoc analysis, but as an a priori analysis plan, we had 28-day admission. And I can tell you that we actually reduced 28-day readmission by 2/3. 28-day readmission is really important. It's really important in healthcare systems that have financial penalties if you're readmitted within 28 days. The UK has this system, the US has this system, and other countries around Europe have this system. So if we can actually keep people out of hospital beyond that 28 days, not only will the patients be better off, but actually the healthcare systems will have to spend less money. What does it tell me? I need to treat 6 patients to improve the outcome in 1 patient. This is as clinical trials should be. We're just upfront and honest about the data. And previous studies, and obviously this is highlighted, and Peter Vextra and myself have discussed this at length. And going forward, we want to do much more contrast and comparison between rescue and HOT-HMV, and we will go ahead and do that so we can understand the difference between the patient populations. But what was different between rescue and HOT-HMV? There was a less stringent CO2 criterion in rescue. The CO2 had to be greater than 45 following cessation of acute NIV. The HOT-HMV patients were randomized if we had a daytime CO2 greater than 7 kilopascals or 53 millimeters of mercury at least 2 weeks after the resolution of the acidosis. And really, it came up yesterday. And this isn't just about the CO2, but it's about timing of initiation of non-invasive ventilation. The HOT-HMV trial enrolled patients with persistent hypercapnic respiratory failure, chronic respiratory failure, which we know from the physiological studies have shown benefit. So it's really important that we took a group of patients that the physiological studies supported. The rescue study, by the criteria of PaCO2 of 45 millimeters of mercury or 6 kilopascals, the inclusion of potential reversible hypercapnia, those patients that resolved. Paddy told you, 50% of our patient screen resolved to normocapnia within 2 to 4 weeks of resolution of the acidosis and cessation of NIV. This is going to be really important data. This screening data has huge clinical implications because we hope to be able to get predictive modelling, because this is now an observational cohort study, where we can understand which patients we need to be seeing at 2 to 4 weeks. Indeed, it may give us an idea Well, let's start NIV in the hospital while we've got them, because we know they're going to be hypercapnic at 2 to 4 weeks, because we do receiver-operator curve analysis with sensitivity and specificity to ensure we look for which level of bicarbonate which actually predicts the high CO2 at 2 to 4 weeks. So there was a lot of issues or a lot of thoughts we've had about this trial, about how we maximise the impact. This is really important for the field of non-invasive ventilation. This is really important because we can profile non-invasive ventilation in COPD in a very positive way in order that we can get better care to our patients. So what about the clinical implications? What's it going to mean to you and I in clinical practice? Well, the COPD have a really poor outcome. We know from the data from Connors that if you have a high CO2, your chance of death or readmission is very high. Mark Elliott's data, which we used to power this study, showed that patients receiving acute NIV, the median time to readmission, as in 50% of the patients were back in hospital, was 32 days. So it's interesting, that power calculation that we took was almost exactly what the HOT arm showed. So this validates the data. HOT-HMV trial has shown the addition of home mechanical ventilation to home oxygen therapy improves 1 year admissions-free survival in patients with chronic respiratory failure, patients with persistent hypercapnia. We only need to add it, or if we treat 6 patients, we'll see a benefit in 1. And really, the driver of clinical improvement, and Paddy highlighted this, and I must highlight it again, that at primary endpoint, the mortality in both groups was identical. It was around 10% when they hit primary endpoint. By the end of 1 year, the mortality in each group was around 30%. We're not affecting mortality. We're actually affecting admissions. And again, it's really important we take on board that COPD patients deteriorate every time they have an exacerbation, which is complicated by an admission to hospital. Major clinical relevance, as I said, about admission avoidance, and the fact is it costs to have the patient readmitted, and with financial penalties in some healthcare systems, it's very costly. And as I said about the post-hoc analysis with the 28-day readmission. So what about clinical practice? I hope, and it already has, we've had agreement within our hospital already to set up a post-acute NIV clinic. Now, based on the data we have, we think that clinic only needs to run once a month. So this is not a huge burden. So what we will do, we'll have a clinic where people come at 1 month following an exacerbation of COPD. They will be assessed, they will have an arterial blood gas performed, and if their CO2 is greater than 53 or 7 kilopascals and their PaO2 is less than 55, then they will receive home oxygen therapy and home mechanical ventilation. And I think it's really important we take everything from these trials and make sure where we can embed it into clinical practice. As I say, if we then analyse the prospective data we have from the screening, we may be able to modify that further, because my worry is leading patients out for 2 to 4 weeks, they may get lost or not come back. You have to arrange transport. So if we can identify the cohort within hospital, we can take the view of setting them up in hospital. But we need to wait for the data to tell us we should do that. As I've said, this has been very much a trial, and it has been at times an attrition and a war of attrition because it's been so difficult to keep going. But there's been people who have really been important. Not only the patients, who you can imagine contributed hugely, and the fact is patients to stay in a trial all the way through to the end of 12 months is phenomenal. But also the HOT-HMV team and the HMV UK network, which we've now built. And then the authors of the manuscript. Now, this does not say who else was involved. There's other people who are involved. There's the research nurses at the centres, the research physios. There's a whole lot of teams involved in this study. And we just got to acknowledge that without the whole team working, this would not have worked. But I've got special thanks, especially over the last few weeks when we received the data in May. Obviously to Patrick, Jill Arbane, Sunita Rehal, who's our trial statistician, who managed to do all this while writing up a PhD. So she really went the extra mile so we could get the data submitted to the late-breaking abstracts for the ERS in London. The other individuals, as I said, has been really important in this trial is Mark Elliott and John Gibson, who've been incredibly supportive, as well as Mike Polkey and John Moxham. But thanks to everybody for helping us deliver this trial. Without the funders and sponsors, we wouldn't have done this. I will like to say we will tot up the pennies at the end, but I'm going to bet you this is one of the cheapest randomized control trials that have ever been developed. And they're all laughing because they gave us hardly anything. So we've delivered a trial at a reasonable cost that hopefully will be important to change clinical practice, or at least inform clinical practice. Be delighted to take any questions.
You see, the biggest difference in the curves are primarily in the first couple of months. And I think it's very comparable to the study of Thomas Koenlein. So you always think, is it a study is being positive because some people, the worst patients might be in the control group. So what's your opinion about that? Because it always strikes me that you see always the same kind of result in this RCTs. What's your opinion?
So I think we've really, as I said, replicated Mark Elliott's data, which was unpublished data, but we used it to power this study. And so really we've just replicated that study, that patients who are given home oxygen therapy or patients, are given standard treatment really are back very quickly and very early. So again, we're not seeing a mortality effect here. Now, we didn't power it to look for the difference. We looked at admission-free survival. So it's the readmission. We know within the UK that if I took the COPD population as a whole, 20% of the patients are back within 28 days. I know that 30% of patients are back within 3 months. So when we delved down in the data and we saw the result, it didn't surprise me because it's admission avoidance that the non-invasive ventilation, the home mechanical ventilation seems to be having.
Okay. And the other thing is, what is really, I think, an important point is that the quality of life, you would suggest that if you decrease the admission rate, which is very closely related to quality of life, that quality of life would be a bit better.
Yeah.
So do you have any clue for it that the patients don't have a better quality of life?
So Paddy and I have thought long and hard about the quality of life, and you'll see the quality of life does improve up to 3 months. But by 3 months, we're seeing this effect of 17 patients moving over from HOT to HOT-HMV. Again, it was madness, we said, cross them over, because we could have diluted out all of the effect. But that's what I think you're seeing a difference at the beginning when the groups are separated. But as these people are crossing over, we're actually impacting on our results. So I think that is the reason. My main worry about, as you probably were, AVCAL showed it was really we know what it did to the patients. They felt miserable, and more miserable than that home oxygen therapy group. So I think in a way, and the way I've spun it, is this maintains quality of life, which means it's not a burden on patients more than home oxygen therapy.
CO2, I think, is very important, and I think to exclude the patient who get normal capnia, I think, of almost normal capnic, I think not a good candidates to get in the trial. I think the other point, I think it's maybe more important to have a positive trial because these are patients who have a lot of exacerbations. And I think maybe we have to focus more on this parameter to find the patient who have the more exacerbation because these might be the good candidates to have this NIV.
Yeah.
So CO2 is important, but I think exacerbation rate might be even more important.
And as we were discussing, I think CO2 is just a reflection of how sick they are and how long-term sick they are. I agree, the things that affects patients is, well, if we drive down their CO2, they may feel a little bit better, but what affects patients is exacerbation frequency.
The acute exacerbations which had NIV treatment, and we could see that there were some that had repeated NIV. And we saw that the mortality was less in these at each of the admissions. But on the long run, it was higher. That's quite okay, because they have many times, and each time is a risk. So it looks like in our acute data that there's a phenotype which are admitted very often. And I guess it could be that they're very fragile, and that they get a little bit more dyspnea at home, and then they are admitted, and they get too much oxygen, and they get NIV, or something like that. And then, how was it then? So what I thought was that when you say that they don't get real exacerbations at home, it's because they don't meet the standard exacerbation definition with increase in change in medication.
No, I mean, they were
Because
having
they just
frequent exacerbations at home. I mean, 4 a year.
Yeah, they just
in
go over
treatment.
a small bump.
Yeah, but we classified our exacerbations. I mean, Visha was on this trial, and you know, and John Hurst, because we wanted to make sure our exacerbations were clearly defined, and you had them as one of 4, which is a patient exacerbation untreated, a patient exacerbation treated, a physician non-treated, and a physician treated. So we were really clear about exacerbation frequency. We can drill down into the data to find out whether these were mild exacerbations or severe exacerbations. And that is part of the process of going through the for us, will be post-hoc analysis, because we didn't actually put that as an a priori plan, but we can delve down that. Your other point about COPD phenotyping is absolutely right. We need to understand in these severe guys the difference between them, because we're not there yet. And I mean that because we've got now data showing marked differences in expiratory flow limitation between a COPD patient here who has the same FRC, TLC, RV, compared to a patient over here. And I can't tell the difference unless I put an esophageal catheter down and measure the intrinsic PEEP. However, when we measure expiratory flow limitation, what we find is there's a significant difference, and we have a relationship between expiratory flow limitation and intrinsic PEEP. So I think if I was going to hypothesize, some of these patients will probably have high levels of intrinsic PEEP in the HOT arm or the HMV arm. And what happens is when you develop an exacerbation and you have marked respiratory flow limitation, those patients will cope with it less because they will dynamic hyperly-inflate very, very early on. So I agree with you, we've got to get smart. For us, we're looking at neurospiratory drive, expiratory flow limitation, physical activity. That is the next stage. From a completely different cohort, we had a COPD cohort, non-hypercapnic, and we did physical activity monitoring. And what we found is the change in physical activity monitoring, so they were active during the day and not so active at night. When it goes to being active at night and less active during the day, hey presto, an admission is coming up. Not surprising, they're coughing, they're spluttering, they're unwell. That's what we know from clinical practice. So I think getting into the phenotyping of these patients is incredibly important for us going forward.
I want to share with you my thoughts about what is, how do I translate this new data to my clinical, and I want to focus on the number 28. And as you mentioned, we should call the patient after 2 to 4 weeks and see if it is coming. But I keep on thinking, will that be in the right time? Will I catch him before he will get readmitted? Shouldn't I...
So can I just stop you there? We hardly saw any readmissions, so be safe. We're going to publish our data which will show you there isn't many readmissions. Our clinical concern about these patients is a concern that we do not believe is founded, and that will help the clinician hugely. Because I walk around worrying about these guys and sending them home. We saw very few missions, and we're talking about 2,000 patients. This is a huge cohort study. This is a huge observational. So I want you to feel confident they won't come back. The first patient we did in this trial did have a pH of
7.34.
And Paddy came to me and said, should we put him in? And I said, what are they got? And he said, oxygen. I went, yes, you know, because we were really worried. And that was really back in February 2010. Didn't come back. These guys are not coming back to hospital until we're inviting them back. But won't it be better if we can amass the data that identifies the guys that are going to be in that position 2 to 4 weeks? Then you'll be able to do it in hospital, and everybody will feel much more relaxed.